Hello, and welcome to the Frontline to Finish Line podcast, your go-to sport and exercise medicine podcast series. I'm Claire Speers, a specialist MSK physiotherapist and Pilates instructor with an interest in aquatic physiotherapy. And I'll be joined by my co-host, Dr. Ralph Mitchell, a GP with a specialist interest in sport and exercise medicine, who has vast experience across both elite sport and the NHS. Together, across this series, we'll be speaking to a number of industry-leading experts, exploring some fascinating topics across the multidisciplinary world of sport and exercise medicine. We're delighted to have you join us, and we hope you enjoy the listen. So welcome to this week's Faculty of Sport and Exercise Medicine Frontline to Finish Line podcast. I'm hosting on my own this evening. Ralph has decided to take a little hiatus from presenting the podcast. We'd like to thank him for all of his fantastic insights. I'm sure you'll miss his dulcet tones. Watch this space for future podcast hosts. Today, we're welcoming the wonderful Chris Meyers to the podcast. Hiya, Chris.
Hi, Claire. Thanks for having me.
Thank you for joining us and giving up your evening. Chris is a clinical specialist physiotherapist. He's pretty ubiquitous. He's done so much. I'm going to give you a quick oversight of some of the things he's achieved in his long career. Not wanting to age you too much, Chris, but
no, it's getting quite long though. You're right.
It is. So Chris, not only is a physiotherapist, he also decided that he wanted to do osteopathy. So he has an osteopathy degree as well. He has a master's in sports and exercise medicine, a postgrad certificate in musculoskeletal sonography. So he's one of the first physiotherapists to achieve that. He's an independent prescriber. He divides his time between Complete Physio, a private clinic group in London, works in elite sport and has worked in England squash, British athletics, for a number of professional football clubs. He is a lecturer, so he's currently lecturing at Queen Mary University of London, University College London, Canterbury University, just to name a few. And he also runs one of the UK's leading providers of ultrasound education. So SMUG, great acronym, the Sports Medicine Ultrasound Group. So we're delighted to welcome Chris today to talk about all things ultrasound injections in MSK. Have we covered that there, Chris?
Yes, it's a bit boring, isn't it? But yeah, it's all part of the journey, isn't it? As to what you end up doing and what you enjoy doing, what you drop, what you keep going. And I suppose I've ended up in this position where I spend most of my life carrying out and assessing MSK injuries and using diagnostic ultrasound. And then, as you say, I do lots of ultrasound guided injections as well. So I spend a lot of time doing that now privately, not so much, not in elite sport anymore.
So what led you to that? What was it about ultrasound and injections that pulled you in as a therapist?
So, I mean, the reason I became a physio is because I really enjoyed anatomy. And I remember knowing all the bones of the body when I was about 9 years old. And I always wanted to be a physio. And once I got my degree in physiotherapy, I enjoyed working in the NHS. I enjoyed I did some elite sport work then. But I definitely was still searching for something a bit more, maybe something a little bit more objective, maybe something a bit more black and white, no pun intended. And I did an osteopathy degree. I did my master's, and actually during my master's, I got an introduction to diagnostic ultrasound. And I can remember the first time somebody showed me ultrasound and showed me what you could see underneath the skin, like there and then. And I was just fascinated. And it really took me back to the roots of why I wanted to be a physio, which was that I loved anatomy, and I still love anatomy. And I feel very privileged that every day I can look under the skin straight away and get more information, because that's what I struggled with physio. It was everything gets diagnosed as like very non-specific, non-structural diagnosis, and I could see that everything was becoming quite non-structural in terms of like anterior knee pain, subacromial pain syndrome, non-specific low back pain, and that's fine, and we don't need to discuss the pros and cons of that, but I liked that ultrasound gave me that new layer of information, another layer of information, and took the guesswork away, or some of the guesswork away, from what I was seeing. So I loved that. And from the day that I started scanning, which is about 15 years ago, I haven't looked back. I was doing unguided injections in the NHS, never really felt comfortable with that. And when you start scanning, you quite quickly realize, you're never going to be accurate from an unguided point without using ultrasound. Obviously, you could argue whether the outcomes are the same, but certainly I wanted to ensure that if I said to somebody I was doing a guided glenohumeral joint injection, and I soon discovered that it's actually really quite hard to do that unguided, and around 50% of the miss, when you start scanning, you're like, hang on, I need to do this ultrasound guided. So it then turns into this, what I think is quite a cool one-stop shop, where a patient comes in, you carry out an assessment, you do a diagnostic ultrasound scan, and then obviously, if appropriate, you can do an injection technique. And that's what I spend my life doing, and that's what we do at Complete Physio. And I think we've sort of got a good reputation for doing that.
Certainly, I think for us as physiotherapists, having that extra bit of information can be so useful, and for sportsmen as well. There are so many applications, and I suppose that leads on to why ultrasound over other diagnostic modalities, and when would you potentially use X-ray and MRI over ultrasound?
Yeah, absolutely. So I think the first thing about ultrasound is that it can be carried out there and then with the patient, and we use this term, it's an extension of our clinical assessment, and it genuinely is that. Ultrasound is very good at looking at most tendons. It will struggle a bit with some of the deeper tendons around the hip, but obviously as machines have got better, which is one of the reasons that so many more people are using ultrasound, is that we're finding out more, we can see more, the machines have got better, but not necessarily more expensive. And so for most tendons, and I see a lot of tendon problems, and I mean by that plantar fascia, Achilles, patella tendon, obviously shoulder is about 50% of what I see, and I think it's brilliant on ultrasound. Obviously your tennis, golfers, elbow decurvens, all of these things you can see beautifully on ultrasound, and you don't need any other imaging. In fact, I could argue that it's a better imaging modality for those tendons specifically that I've just mentioned. You certainly get a better spatial resolution on ultrasound, so you can see the fibular pattern of tendons much better than you can on MRI. And a lot of the time, if your clinical question is around a tendon, particularly those more superficial tendons, then you can gain the information that you need there and then. And I still say it to the day, there's so many unnecessary MRI scans carried out. Obviously, MRI scans are great when, the way to think about it, or the way I think about it, is when you carry out a clinical assessment, you are trying to ascertain maybe 4, 5, 6 working hypotheses. And then if you can image them on ultrasound, so for example, if you're looking at a lateral ankle, a lateral ankle sprain, you're going to be looking for potentially a fracture, which you can see beautifully on ultrasound, which is underestimated. You're looking for a ligament injury, a tendon injury, and then basically you just use your ultrasound to prove or disprove your hypothesis. And normally that goes with the patient having quite a specific localized pain.
Yeah.
If you've got a deeper pain, so i.e. a joint, or you want to know about the meniscus, or if you think there's an osteochondral defect in the knee or the ankle, then obviously you're going to need an MRI. And also MRI can be very useful if you're not sure of your diagnosis, because it gives you a really nice overall picture, for example, of a joint. But if you can pinpoint the pain on with your clinical assessment, then ultrasound is great for looking under the skin. X-rays, they've been around a long time, and there is a massive role for X-rays. Certainly some things I've learned over the years, that X-rays are not as sensitive as I thought for picking up fractures. And I find probably every couple of weeks I'll find a fracture that is seen beautifully on ultrasound, but is not seen on an X-ray. So things like avulsion fractures of the lateral ankle, avulsions of the bifurcated ligament of the calcaneal cuboid. These are all quite common problems. Radial head fractures are seen beautifully on ultrasound. Some people will use it for scaphoid. I don't, because it's tricky, but if, I know I've got an A&E colleague that's using it for scaphoid fractures. Greater tuberosity fractures are seen beautifully on ultrasound. And ultrasound will just see the cortex of the bone, so you can see if there's a break. Basically, you don't necessarily know where that break goes, but you know there's a break. And the sensitivity for ultrasound and picking up fractures is extremely high, particularly in the hand and foot, where a lot of the research has been done in A&E.
So I guess you're using that to get the clues and then maybe refer off.
Yeah, absolutely. So it's very sensitive for picking it up. You may then go and get further imaging to clarify that. But sometimes you don't. You get if you've got all the information you need to manage that patient the right way, then you don't need to go and get other imaging. And that comes with experience as well.
Yeah. And can you do dynamic movements then? Because you've got the beauty of being able to get the patient
Yeah.
moving.
Yeah, and I think that's one of the beauties of ultrasound is that obviously we assess movement, don't we? And MRIs, X-rays, often they're done in static positions. So good examples of using the dynamic nature would be if you have a ligament injury. I always say it's easy to find out if a ligament's injured, but what you want to know if that ligament still functions in the right way. So does it stop that bone from moving away from that bone? And is there a good end feel? And you can combine that with your clinical assessment. So good examples of that is obviously any ligament around the ankle. MCL, particularly around the knee, is really good. Posterior impingement of the ankle, you can look at it dynamically. Anterior impingement of the ankle, that knee to wall type pain, you can look at that. You can look at dynamic tests at the wrist, looking for scaphoid lunate. You can look at dynamic impingement tests or dynamic tests on the shoulder, whether it's looking at the posterior joint for sort of your internal impingement. You can look at dynamic movement of the bursa under ultrasound, although that is not a sensitive test, as in they've found as many symptomatics as asymptomatics may have this thing called bursal bunching. But yeah, you can look at fat pad impingement at the knee dynamically. You can look at anything snapping, so you could look at ITB issues. You could look at psoas tendon snapping at the hip. So yeah, there's loads of applications that you can use it for, and that's growing as well in terms of us knowing more about what we can use ultrasound for. But yeah, the dynamic nature is very helpful, and sometimes it picks up things that any other imaging that is not dynamic is not going to be sensitive to.
And from a training perspective, for both physios and sports and exercise doc,
Yeah.
I think there's a huge variation, isn't there, in the training that's available. So for people to be assured that their healthcare provider is the right person doing that ultrasound scan, what would you recommend people look for?
Yeah, absolutely. So we on our SMUG courses, we get as many sports doctors as we get physios. And I think generally speaking now, everybody should be looking towards doing a postgraduate certificate in musculoskeletal ultrasound. That certainly gives you that bit of paper. It takes you through a formal learning process, which is really important. And obviously you've got deadlines, you've got to get stuff done, and you've got to get your logbook done as well, which is 250 scans. 100 supervised or assisted scans and 150 unsupervised or unassisted scans. And in our course, we audit those 150 unassisted, because there's no point just scanning and never knowing if you're right. You've got to map it against somebody else. So I think the PG cert is the way to go. That doesn't mean that you can't get started. We run a 2-day introduction course, and then people do get started afterwards, but it probably needs to be in more of a supervised environment.
And then you talked at the beginning about the importance of having ultrasound guidance for injections.
Yeah.
So can you tell me a bit more about the types of injectables you're using? Because there's so many now.
There's so many, and there's a growing amount of injectables. So obviously, traditionally, steroid is the one that we've used a lot of. I definitely think we're using it less now, but steroid is still a very, very effective option for certain conditions. So anything where you've got an inflammatory component, so a tenosynovitis, for example, dequervins, excellent for. I still use them for subacromial bursa to try and give us that sort of window of opportunity, particularly if there's night pain. AC joint, very effective. And frozen shoulder is probably 40% of what I do. So we'll do a lot of hydrodistensions. And sometimes they're brilliant, sometimes they don't work well. But that gives you an idea of some very appropriate options where we would still use steroid.
Yeah.
I've used hyaluronic acid since my NHS days, so probably around 12, 13 years. I still use hyaluronic acid predominantly for the knee.
Yeah.
I do use it on hip, occasionally ankle, first MTP. I would say that knee is where most of the evidence is, and obviously, evidence is let's be honest, the evidence is not great for any injectable. It's the problem I have, and I do a lot of injections, is it's very hard to know or predict who will improve with the injection, particularly hyaluronic acid. And that's what makes it difficult. The imaging doesn't necessarily help us, but what we do know is some people do really well with it,
Yeah.
and some people don't.
And it's quite a mechanical substance, isn't it? The hyaluronic acid.
Yeah, so it's obviously more viscous
Yeah.
than steroid. There's lots of discussion around the mechanism of action. I would suggest that we don't exactly know. It does have some anti-inflammatory products. There is talk about whether a high molecular weight or low molecular weight of hyaluronic acid is a good thing, and whether it has shock absorbing capacities, whether it has more lubricating capacities. Either way, I think it's very hard to know who's going to get better with it, the patient in front of you. And I always say the best candidate is somebody with mild to moderate osteoarthritis of the knee, who's not overweight, who's trying to remain active and is prepared to put in a strength training program. But actually, that's the same for any intervention.
Yeah.
They're always going to do better than somebody that's overweight, that's not exercising, that's sedentary and has moderate to severe arthritis. So it's not actually that helpful. But so hyaluronic acid, and as you know, as physios, we were allowed to do PRP. The recent regulation, a few years back now, means we can't do PRP. I did it for a couple of years. Our sports doctors, Lorenzo and George, do it in our clinic. And PRP is definitely getting more popular.
Yeah.
Again, we don't know what the patient in front of us, whether they're going to be the one that is a responder or a non-responder. And it's very hard to predict from any imaging or any clinical assessment. Certainly, I think there's two reasons that PRP has grown in popularity. There's probably three reasons, actually. One is that people can make a lot of money from doing it. I think we need to not be naive to that. The second thing is that, generally speaking, we're more aware that there are negatives to steroid injections, particularly around joints and tendons, or into joints and tendons, sorry.
Yeah.
And therefore, people who are not getting better are looking for another option. And PRP provides another option because, yes, it's not a drug, it's natural, it's supposed to be more regenerative rather than just symptom management, although I would definitely argue that it is just symptom management.
Yeah.
So I think there's a few reasons why PRP has gained momentum. And then you're getting into other things like stem cell therapy, lipogems. There's a new knee injection called arthrisamid. And a lot of these are starting to get momentum. And all of them are more natural products, if you like. They're not steroid. They're not drugs in theory. They're medical devices. So, and patients love that. At face value, patients love the fact that it's not a drug and it's natural and it's trying to preserve and regenerate, which I would love to say they are, but I'm pretty sure there's not the evidence to, you always get case studies, look at the MRI before and after, but what they're trying to do is reduce pain. And that's what we're trying to do essentially. And that's the only reason. Generally, the patient is there, and actually you shouldn't be injecting non-painful joints anyway. So they're really for pain management. But I think it's getting harder for patients to know what's right. When do you do a PRP over a hyaluronic acid over a steroid? I would suggest that a lot of the stem cell, the arthrisamid, these injection PRP that are costing thousands of pounds sometimes, if it was a knee, I'd probably try a hyaluronic acid injection first. Just because it's a one-off, well, it's not necessarily one-off, but it's one injection at the time, and see if they get relief. It's less expensive. there are not the side effects of steroids. So I think every clinician, whereas I know lots of clinicians that will go straight for the expensive ones.
Yeah,
And actually it comes down to the patient.
yeah,
And you just have to inform the patient of these are the options. We're very upfront with our patients. We don't know if this is going to work. There's a chance it definitely doesn't work. Well, not
yeah.
definitely, but there's a chance that you're that person that it's not going to work on. Do you understand that? Yes. You've got to really make it very clear, particularly in private practice. You've got to manage the patient's expectations. And if you don't, you're just setting yourself up to fail.
Yeah. And from what I'm hearing, it's very much about that buy-in, isn't it? If you can
Yeah.
find something that's painful, give somebody relief, and give them a window of time to actually be able to participate in their rehab and their strength
Yeah.
training, that can be a game changer for people.
Absolutely. And certainly in our clinic, or certainly my own personal caseload, is I will see a lot of referrals from surgeons or people that have seen surgeons. And, let's be honest, a lot of surgeons will give them a surgical option.
Yeah.
And some will not give them other options.
Yeah.
So some people do, and different surgeons have different thresholds for injections. But I definitely see that caseload that have tried an awful lot. They've tried physio, they've tried this, they've tried that. And they want to try something else before thinking about surgery. And certainly if it was my knee, I've got a bit of a dodgy medial compartment, I will exhaust all conservative measures before I go under the knife again.
Yes.
And I think that's reasonable. And patient education, managing those expectations before you've done anything is the most important thing. And obviously outlining all the potential side effects.
Yeah.
We've all had cases where even things like hyaluronic acid have flared up joints and patients have been unhappy. So, and you only learn this through doing it for a long time.
Yeah.
And so, yeah.
Thinking about those side effects, I think there's a lot of fear around steroids, isn't there? The number of times people say, I don't want a steroid injection, it's
Yeah.
there's also always questions about how many am I allowed to have. So just around those themes.
Yeah. So I think when somebody says they don't want a steroid, I think the first question is not just to accept that they have got all the information they need to make that informed decision. So an example of that will be, only a few weeks ago, I had a patient said, oh, I don't want steroid injections. I was like, oh, why is that? Oh, because they can make you fat. And I was like, okay, sit down. Let's talk about this. Why don't you want a steroid injection? Because Barbara down the road had one done and she was terrible afterwards. Okay, well, that can happen, but that's not always the case. So it's trying to find out where those fears come from and whether they are realistic fears, whether they're over exaggerated. But certainly you need to address them, give them the information. I think the big thing that I spend a lot of time trying to talk to patients about is the side effects around, look, this may not work. Obviously, there's side effects such as infection, which you have to speak to patients about whatever injection you do. And then obviously around steroid, you talk about how many injections you can have. And I think it does vary. If you look at a frozen shoulder, for example, I'm quite happy to do 3 hydrodistensions if they've got a bad frozen shoulder, but I'd be less happy to do 3 in a knee over a short period of time. And I often use the phrase, look, the more steroid injections you have, the less they work, and potentially that they can speed up the process of, for example, osteoarthritis. That doesn't mean people don't want to have them done. It just means they need to be aware that they shouldn't have too many. We're using it as a window of opportunity. And they need to know, because you've also got to manage the other side. Oh, well, I've had an injection, it only gave me 2 weeks relief. Whereas Bill down the road had an injection and the pain's never come back. And so you've got to manage that as well. You've got to manage all, if you like, potential results from that injection, because you don't know what's going to happen with that patient in front of you. So in terms of how many injections, I think I will always say that other than frozen shoulder, I consider this to be a one-off injection. That doesn't mean we won't repeat it at some point, but certainly we need to do this as a standalone treatment. And then after this, we're going to change X, Y, Z. So the thing I'll sometimes say to people is, if I do this injection, you almost make a little bit of a deal. If I do this injection, then I don't know, for example, with knee, you need to lose weight,
Yeah.
and if you don't, you'll be back in 3, 6, 9, 12, months asking for another injection. I won't say I won't do it, but we're not getting where we need to be.
Yeah.
Um,
I think
or
that's
if
really
it's
important.
yeah,
Yeah. It's giving the person opportunity to make that informed choice, isn't it? And
yeah, and I think the injection can start that process and give them that motivation.
yeah, absolutely.
Yeah. Or it might be, I will we're going to do the steroid injection, but this is your strength deficits. You're 20% down on your quad strength. We need to get that up. Otherwise, we're not changing anything. So I would always say, if you do a steroid injection, you need to do something else as well, not just a steroid injection. That's why, as a physio, and why we have sports docs in our clinic, is that an injection should never be seen as a standalone treatment.
Yeah.
Lorenzo, our sports doc, always says, yeah, do an injection. That is just an adjunct to XYZ. And I think that's the best way of looking at it. And unfortunately, there's lots of injections that are done where it's not part of an overall package.
Yeah. People see it as a magic bullet, don't they? That thing that's going
They
to get rid
do.
of forever.
Yeah, yeah, yeah. And sometimes people will say that steroid is a holiday drug. So
Okay.
it's skiing season. We're in Chelsea. Everybody seems
Yeah.
to ski it. Yeah. So I do have a group of men and ladies that will come 2 weeks before their skiing holiday, and we do a steroid, and it gives them that holiday for maybe 2, 3 months, and they enjoy it. And when you weigh it up and you tell them, and they're like, well, I know I'm going to have a joint replacement at some point, but I want to enjoy my time with my kids at the moment. And so
Yeah.
you have to look at what injection you do is as much reliant on the context of the patient and what they're trying to achieve, as it is around what I believe is the right or the best injection for them at that time. Because it might not be what you think, and as
Yeah.
long as the patient's fully informed, then you need to respect that,
Yeah.
and get a treatment planned accordingly.
Going back to kind of those hydrogels we talked about,
Hmm.
I'm quite naive to the hydrogels. I kind of understand about steroids. I get hyaluronic acid. I get the platelet-rich
Yeah.
plasma. What's the difference with these? How do they?
Yeah, so they are fundamentally quite different. So the hydrogel we're talking about is arthrisamide, and I don't personally inject it. It is something that we are going to start doing because I'd like to offer it as an option. Um, the and people ask you as well.
Yeah.
People say, "Oh, what about this, Chris?"
Are physio
Um,
allowed to? Are we? Is it?
yeah, it's classified as a medical device, so it's slightly different in the classification to hyaluronic acid, but it's in that sort of bracket, if you like.
Yeah.
But they do hydrogel in theory is a permanent implant, so you have to take antibiotics beforehand. Um, I don't. I assume that's yeah. Somebody's told them they need to do that.
Yeah.
And then my understanding, I'm no expert in it, but my understanding is that and this does make sense to me, is when you've got a swollen knee, it's specific to knees, by the way. When
Yeah.
you've got a swollen knee, and you see this under ultrasound, the synovium, which is the lining inside the capsule of the knee,
Yeah.
that's what produces the synovial fluid. And if that gets inflamed, irritated, then it will produce more fluid, i.e., you get a swollen knee.
Yeah.
So what the hydrogel does is you inject it, it has to be under ultrasound guidance, like all of these. You inject it into the joint, and my understanding is it then goes into the synovium. So it almost, I once heard it as a fire blanket over the synovium,
Hey. Yeah.
and
It's
it actually starts to sort of invaginate the synovium, so to try and actually become part of the synovium and therefore reduce the reactivity of the synovium. That's my understanding.
yeah.
And one of the things that certainly the research, but more from people that do inject it, they say, this could take 2 or 3 months to work because it's got to become part of that synovium, and blend with that synovium to affect what the synovium is doing. So essentially, you end up with a less inflamed synovium, and
Right.
that definitely makes sense to me. So it's trying to, when you have an arthritic knee, in fact, when you have lots of different problems in your knee, but you end up with a synovitis, which is
Yeah.
inflammation of the synovial wall. And so therefore this is working directly on the synovium, which
So
is
it's not,
different to the others.
yeah, it's not affecting the cartilage. It's not having an effect on the
No,
ends of the bone.
not my understanding. So I quite like that idea. It's
Yeah.
more viscous. I have injected it on a cadaver, but
Yeah.
it's more viscous than the hyaluronic acid, so it is thicker. Not crazy thick. It's
Yeah.
not like a, I don't know what when, I don't know. You sort of imagine a silicon implant, don't you?
Yeah.
Or I do. So it's not like that. It's thicker than hyaluronic acid, but it's not crazy thick. Because when I
Yeah.
injected it, if something's really thick, especially in a 1 ml syringe, it can be quite, with a green needle, it can be quite hard to get in. But this wasn't. So
Interesting.
yeah, so we're going to start trying it. I've sent some patients to our sports docs to have it done, and I've asked them, and honestly, at the moment, it is like all the others, mixed results.
Yeah.
What I would say about the company Contura who supply it, they are getting a lot of data.
Great.
Now you can argue how accurate that is and where do the dropouts go and that sort of thing,
Yeah.
but they are getting a lot of data, which is good.
Yeah. It's interesting. I guess you're only going to be able to do it in people with mild to moderate
Same
arthritis.
as anything. Same as anything.
Yeah.
If you've got a severely arthritic knee,
Yeah.
then although the company will claim that, they want to, I don't quote me on this, but they want to get people off the total knee replacement waiting list.
Yeah.
So they are looking at that market as well. And there is there is a trial coming out, a big trial, I think, coming out this year. Um, I don't know if it's an RCT, but a big
Yeah.
trial with the results coming out at the end of this year. So that will be interesting. They are proactive with getting their results, that's for sure.
Yeah.
Getting
Well,
their data.
yeah. Yeah.
Yeah.
Fantastic.
But we'll see. Only time will tell with these things. And
Yeah.
and for me, I've got to start doing it myself to really know.
Yeah.
But I feel my gut feeling will be the same, is that you've got a patient in front of you, you've got a few different injection options, and it's quite hard to know which one to use. I think we know when to use steroid. I do
Yeah.
think we know when to use hyaluronic acid, but when do you use hyaluronic acid instead of PRP? Or what some people do is put them both together.
Okay.
But then you don't know what's working.
Yeah.
And then obviously you've got your stem cells and that, and something called BMAC if we're looking at knees, bone marrow. That's bone marrow that's taken from like the hip or the ilium and then
Yeah.
injected in. And I think most people would accept that we're then getting into not experimental, but certainly we're in that research phase where we're still finding out whether this works, but we know it's safe.
Yeah. Yeah.
And
And
being
that,
safe doesn't mean it will work.
yeah, absolutely. Two separate things, but
Yeah.
important that it is safe.
And the other thing with arthrisamid is that it's supposed to be a one-off injection. You
Okay.
can do it more than once, but it's like sold as a permanent injection,
Yeah,
which sounds great
absolutely.
if it
I
works.
Yeah, only if it works.
Yeah.
Thinking about kind of potential physios listening to this podcast, and
Mm,
I think there'll be a lot of people listening thinking, wow, this is really cool that you have a
mm,
physiotherapist working in this space, because it's not always something that we see as career
no.
option.
Mm,
Um, just thinking about the kind of I suppose the governance around it all and the
yeah.
risk, and especially as an independent prescriber, for those that are kind of really novel to the just
Mm.
injectables and being able to prescribe, what are the key kind of processes for physios to go
Yeah.
through?
And obviously with the smug stuff, I probably get an email a week saying I want to start injections, and it's like,
Yeah.
okay, hang on, what? It's a long process. So I could go on about this all day, and there's stuff on our website, our smug website, where I go through this, and I'm happy for people to email me. But the first thing is, to do a good ultrasound guided injection, you have to be good at diagnostic ultrasound. And
Yeah.
actually, you should never separate the two, because your diagnostic ultrasound helps you and gives you information as to what sort of injection potentially you should do. So you need a good diagnosis before you think about an injection. So you've got to learn how to scan. So let's say that takes a year minimum to get to a very basic level. You've then got to learn how to do ultrasound guided injections. So you've got two routes for that at the moment. One is to go and do postgraduate certificate or a module in ultrasound guided injections, or what some people will do is they will actually just do an unguided injection course to get the injection basics. And then because they've already got their diagnostic ultrasound, they just bring the two together. So we run a cadaveric course, 2-day course, where people that have done that course and done the diagnostic ultrasound can start to bring them together. If you can scan doing guided injections, it's still a skill, but it's much easier once you've got your diagnostic ultrasound scan, because you can find the target really quickly, and then you know how to stabilize and you can pop the needle in.
Yeah.
Independent prescribing, if you work in private practice, you've got to be an independent prescriber. Yes, the artemisinin, forget PRP for physios, artemisinin and hyaluronic acid, you don't need to prescribe them, but you will be limiting what you can do if you're not. And also you then can't use local anesthetic to make it less painful.
Yeah.
And patients definitely like that, even if you just use a small amount. So to be an independent prescriber, that's another course, as you know, that's another approximately 10-month course.
Yeah.
And then once you're qualified, now within that qualification process, you need a supervisor for your injections, you need a supervisor for your independent prescribing, you need a supervisor for your diagnostic ultrasound qualification. And they're not necessarily the same people. So it's you need massive time and input from supervisors to do that. I did all of this in the NHS.
Yeah.
And that was not just the easiest, that was the best way of learning. Because the other thing is you've got to get good at this. I think it probably takes, for example, on our PG cert and ultrasound guided injections, you have to do 35 guided injections. And in theory, you're signed off as competent, but you're never going to cover all the joints. I think it takes around 250 injections to get okay at it.
Yeah.
I really do.
You just need the volume.
You need volume, and the NHS is amazing for that. I would do 10 injections in one day. Private practice, if you don't have a reputation for doing injections, which you don't at the beginning, you are going to find it very hard to get the numbers and therefore develop the skill set. Now, I know lots of people that have done, well, do I know lots? I know enough people that have done it in private practice, but they're very well networked. They've got a guy that could help them with that supervision. They've got a doctor, GP mate that help with the independent prescribing. You know, it's that sort of thing. So from the beginning to the end, it's probably a 3-year process, and then you've got to get good at it.
Yeah.
And it takes a long time. And so I always say it's a bit like learning to play the guitar. Some people pick up a guitar and they're bloody brilliant at it, within 6 months. Some people pick up the guitar and they're terrible at it 2 years later. And because it's basically a motor skill.
Yeah.
And you need the supervision, you need to study, you need to sit there and this is my ultrasound machine. You need to sit there and scan yourself, scan your friends, get good at it. It's a long learning process that most people don't understand at the beginning. They soon understand, and it's a very, very satisfying learning process, particularly learning the ultrasound. Independent prescribing, I found a little bit less satisfying. And the guided injection stuff is fun as well. So, but it does take a long time. And I would only suggest that experienced clinicians should be engaged. It should be going through that. But if you're 1, 2 years, 3 years qualified, do not look towards doing it at the moment. Try and develop your clinical reasoning skills, nail your assessments, get some good experience, and then go and learn diagnostic ultrasound. Don't wait 10 years though, because diagnostic ultrasound changes the way you think about things. Even if it's just relearning the anatomy, but learning it actually correctly, because the books don't always do that. So it's a long process, but it's a very satisfying process. But it does take time. A lot of people I hear go, yeah, I just want to do guided injections. But it doesn't work like that, particularly not as a physio, because we are only insured to, first of all, carry out a diagnostic ultrasound scan on a patient that we've already clinically assessed. So it has to be done together. We're not providing just an ultrasound clinic service. We are doing the whole thing. And that's very important how you market yourself as well. When it comes to injections, you need to have carried out an assessment on that patient. We're not just a guided injection service. And same for sports docs. We're doing the whole thing, because the imaging should be done alongside the clinical assessment. And obviously a lot of people refer off to radiologists to get it done, but certainly in the NHS, the waiting lists are very long, aren't they? So I think it's much better if somebody can do the whole thing.
One go. Yeah.
Yeah. Makes sense.
It really does. And I think I
Yeah,
completely back, I did, going back many years ago now, I did my injection course, not guided. Um,
yeah,
and I do think I'm quite good at my anatomy. I think my palpation skills and, my landmark identification is pretty good.
yeah.
I was not happy injecting blind.
No,
Kind of,
doesn't feel good, does it?
there was a couple of maybe where I didn't quite get where I thought I was getting, and
Yeah,
I don't really like doing this. So, yeah, that was
yeah.
the end of my injection career.
Yeah, well, we on our cadaveric course, we occasionally get people, normally GPs. Oh, I've been doing this for, oh no, actually normally orthopedic surgeons. I've been doing this for years. I always get into the subacromial bursa. I'm like, okay, well, there's a cadaver. Get into the bursa, and
Yeah,
then we'll scan after and see if you're in it. And they're not in. If
uh,
there's no conversation, it's like, okay, you're not in because people say, well, the pressure's different. You could be injecting into a rotator cuff tear. There's very minimal pressure on that. So it's always good. Now, obviously, you can argue the accuracy, but yeah, for me, anything should be done under ultrasound guidance. I appreciate a knee. 8 to 9 out of 10 will get in the joint, and if you're an orthopedic surgeon, you're going to be better than a physio that's just trying to get in the knee because obviously they're experienced from a arthroscopy point of view. But
yeah,
certainly, if you're injecting hyaluronic acid, PRP, arthrisamide, these things that cost quite a lot of money, and I would argue steroid. You don't want steroid going into the fat pad where instead of into the joint, then it should be done under ultrasound guidance. And what's important is if it doesn't work, then at least you're in the joint. When I was doing them blind or landmark guided,
yeah,
then a patient would come back after a frozen shoulder injection, and I'll go, right, how is it? And sometimes they go, yeah, it's brilliant. Sometimes they go, I did nothing changed. And in my head, I'm like, that's because I don't know if I was in the joint.
yeah,
Well, let's try another.
yeah. Just
You know?
takes away that ambiguity, and also
Yeah,
everybody we know everybody's anatomy is different.
yeah, yeah.
I'm sure you see that on
Oh,
the
you do massively, massively. Yeah, yeah, yeah.
um,
And also I mean, when we worked in the NHS, with our GPs who did unguided injections, we would say, look, fine, if you want to do one unguided, do one unguided. But if it doesn't work, don't do a second unguided. Let's get a bit more information.
yeah,
And then there's certain injections like getting into a glenohumeral joint that you should get into a hip joint, getting
yeah,
into a lateral bursa. All these definitely hip joint anyway. You need to do it under ultrasound guidance. And I have so many patients that have unguided injections and it doesn't work, and I do a guided injection and it works.
yeah,
And patients they're onto this. You
yeah,
know, how does he know? How did he know it was going in the right place? Well, he didn't.
yeah. He's got
Sometimes you can be
yeah,
really sure. Sometimes you're not sure. Sometimes
yeah.
but different. Like for example, the AC joint. The AC joint is the most superficial injection that we do, and we know that half of them, 60% of them, go in the joint, and the other lot don't.
Wow,
So
that's
it's even the AC joint.
miss
And
rate.
people go, "Well, I know I'm in the joint. Yeah, they got better." Well, it doesn't necessarily mean that.
Yeah,
Um, so look, there's lots around it, but certainly when you start scanning it, you realise that, as you say, everybody's anatomy is different. You have osteophyte, like an AC joint. You've got a massive osteophyte that's coming off the clavicle and the acromion. You can hardly get into the joint. Even under ultrasound, you have to find your way round into an area where you can get the needle in.
yeah,
So there's just so much you don't know, and as long as people accept that, that's fine.
yeah,
And as I say, try one unguided injections. Maybe that's up to you. Depends where you work. Certainly in private practice in London, I think that's unguided injections are a bit frowned upon, I would say.
yeah,
Um, Certainly it's different in the NHS. And when we're in the NHS, we had this, okay, try one, but don't try a second if it hasn't worked or
yeah,
didn't give you the response you needed.
yeah. Amazing. Thank
Yeah,
you so much, Chris. That just the
that's
passion
okay.
and knowledge just shines through. I've really enjoyed
Oh, well, I love my job, and I think I've been doing it 25 years. And I think what I would say is you don't want to specialize too early, but you do need to find your thing during your career. Um, and if you're talking specifically about
Yeah,
sports doctors that want to work with MSK injuries need to scan.
yeah.
I don't think there's any two ways about it now, and you need to start as soon as possible.
Why do you say
Um,
that?
because I feel that why do I say it? Because I think that if you're a doctor working in private or NHS, I just think you should scan, because I think you need to get more information, and you're often going to be the one that's doing the diagnosis. Not that physios aren't. I mean, we do that in clinical time, and I think if you can gain more information on that first appointment, I think that's important. And also, I think I can openly say that sports doctors, particularly in the NHS, have struggled to find consultant roles and develop services. And I think leading on this sort of stuff and getting it away from radiologists, because there's just the waiting lists are too long. I think that's where sports docs can really help. Does that make sense?
Absolutely, yeah. It's
Yeah,
them a bit more of a niche for themselves where they
yeah,
sometimes do that in the NHS setting.
yeah. I think that's it. I think I've said that. That's what I mean anyway, is that it's
It's
physios can go off and do different things, can't they? But if you're a sports doctor, I think ultrasound needs to be fundamentally part of what you're doing. I think you should be, and I'm pretty sure the FSCM guidelines will say that by the time you're a consultant, you should be competent in this. I believe it is part of their core competencies. But the reason I say it is I see people that are 1 year off becoming a consultant, or even are consultants, and they don't have the ultrasound scans.
yeah,
The ultrasound skills.
yeah. And it
So
adds value to what they're doing for them
I
and
do. Yeah, yeah. And for anybody that's learning ultrasound, if you're going to do it, you've got to commit to it.
yeah,
It's not easy. It's operator dependent. It's a long learning curve. And if you're going to get good at ultrasound, particularly as a physio, you will compromise your other skill set, because you'll see me. I'm not in the gym, Claire, doing the ACL rehabs anymore, am I?
no,
Because if I'm spending all my time in the gym, I'm not getting good at this and getting lots of patients in and seeing lots of pathology and getting my experience that I need to be a good physio that uses ultrasound.
yeah, absolutely. And that
Cool.
doesn't take away from anything that you do as a physio. I think
Mm.
you found the passion, you found where you can add so much value to the patient's journey.
Yeah,
That teamwork and working as an MDT. So
yeah. And
it's
that's what we try and do at Complete. And I think most of the time we do it. And I always say, if you can't get somebody better, then you need to know somebody else that can. And if they're in your clinic, then that's great, isn't it?
yeah, absolutely. Thank you.
Cool.
That sounds like a great place to wrap up.
Brilliant.
Thank you so much, Chris.
That's
Really
all right. Thank you for your time, Claire.